Hi everyone, it's me, Shara Benali. I am doing my final clinical presentation on a patient that I saw last week in clinic. So this chief complaint was a 17-year-old male that was brought in by his mother and accompanied by his girlfriend here for a follow-up of hypothyroidism. The HPI this is a 17-year-old male with a history of congenital hypothyroidism that's been non-compliant with his medications for the past year, now showing signs of growth failure, normocytic anemia, renal impairment, transaminitis, depression, cognitive slowing, and medication non-compliance. During this visit, a lot of time was spent on talking about the importance of maintaining normal thyroid function with the patient, his mom, and his girlfriend. So the history of this patient, social history of this patient is he's a 17-year-old that's currently attending a local high school. He's in a relationship with a girlfriend, like I said, who was present during the visit. And mom states that his grades are good. He's not failing any classes. He's doing well. And he lives with both parents and 5 other siblings. Family history is mom and maternal grandmother both have a history of hypothyroidism. Mom is currently taking Levo or Synthroid, so she's well aware of the effects of hypothyroidism and the importance of taking the medication. So this 17-year-old's medical history: he was born with congenital hypothyroidism. He has a history of speech delay and growth delay, likely due to low thyroid levels. His immunizations were all up to date, but he did need the flu shot at the visit. Current medications include vitamin D3, diclofenac, topical gel cream for pain, ibuprofen as needed, and Synthroid 0.125 milligrams PO daily. He has no known drug allergies. The review of systems: the general system is he was tired appearing, the flat affect and slow speech. He was slow to respond to questions. The HEENT system, he wasn't sick at this visit, so there was no cough, no nasal congestion, no complaints of a sore throat. His CB system, he had a slow heart rate. His heart rate was 58 at the time of the visit. GI system, he had no vomiting. GU system, he reported that he voids without problems and no history of constipation. His skin, he has dry skin with brittle fingernails that you could see. So my differential diagnoses for this particular patient was: the first one, hypothyroidism. Second one is anemia. Third one is the pediatric growth hormone deficiency. So my physical exam: his height was 60.94, temperature was 97.0, pulse 58, Respir's 16, blood pressure 96/58, O2 sats 100% on room air. His weight at this visit was 44.64 kilograms. His BMI was 18.61 with no pain reported. So looking at this 17-year-old male's growth charts for height, weight, BMI, he was way, way below the norm for all three. Reviewing previous visits, he had always been below the lowest percentile on the growth chart. And this was reviewed with mom and the patient himself. Growth charts were shown to both of them. So the general system: he's pale, tired appearing, slow speech. The HEENT system: eyes were non-icteric. There was no conjunctival injection with moist mucous membranes. His neck was supple with no lymphadenopathy. No masses were palpated. His CV: he was bradycardic. Cap refill was less than 2 seconds. There was no murmurs, rubs, or gallops noted. Pulmonary system, respirations were within normal limits. He had good air movement, no accessory muscle use. Lungs were clear to auscultation, and no work of breathing noted. His abdomen was soft, non-tender, non-distended. Musculoskeletal: he was complaining of pain in his lower back, especially in the left paraspinal muscle area. There was no vertebral bony tenderness noted. Dermatology system: skin was cool and dry with brittle fingernails. So going back to the differential diagnoses, looking at his labs, his TSH levels were way below norm. He did have some signs of anemia in his recent lab work that was done within the past 3 months. And you could tell by just his general appearance that he was fatigued, tired appearing, pale. But some of this, it was hard to determine if it was because the time of visit, which was at 9:30 during Thanksgiving break. So it could have been multifactorial of a teenage boy just being tired from staying up late with his girlfriend, or was it the effects of the low thyroid? That was something my preceptor and I were trying to figure out. So for the hypothyroidism, the plan was that it was due to his non-compliance with medications. So there was a lot of time spent talking to the 17-year-old male and his mom and his girlfriend to figure out ways of how they could get him to take his medications. Talked about him having his own phone, setting an alarm for Monday through Friday where he would have to turn off the alarm on his phone, which would hopefully trigger him to take his medication before he went to school. The second thing was mom on the weekends would help remind him to take his medications. And we also got the girlfriend involved, and we asked her she could be another alarm by asking him every day, did you take your meds? Did you take your meds? And if he didn't, telling him you need to take your meds. But the one issue that my preceptor had was what dose to start him on, because the dose that he had currently ordered was 0.125, which is the norm dose for Levo. And according to current guidelines, oral Synthroid is the treatment of choice. The starting dose for T4 is 10 to 5 micrograms per kilogram per day. And the lowest Synthroid tablets are 25 to 50 micrograms. The other goals of treatment, according to current guidelines, is to assure normal growth and development by restoring serum T4, normalizing serum TSH between 10 to 16 micrograms per liter, and follow up depending on when treatment was initiated. So my preceptor, she consulted with the University of New Mexico Hospital and spoke to the pediatric endocrinologist, and he suggested or recommended that instead of starting this particular patient on the 0.125 micrograms, to start low and over the next few weeks, months, to slowly titrate up, because if you start high, it could cause negative consequences for this young man. So new orders were put in to start at 1/3 a dose of Synthroid, to give the flu vaccine. For his complaints of low back pain, talked about proper stretching, because of his out of sync labs. There was a lumbar x-ray that was ordered to make sure there wasn't any chances of a fracture vertebrae. So that was done that day, this day of clinic. And for his anemia and depressed mood, we're just going to follow up with labs to make sure that his H&H normalizes. And we didn't want to add more medications until he starts becoming more compliant with his Synthroid. We're gonna see, this kid is gonna get followed up in clinic in 3 weeks for medication compliance and just overall depression screening. So that was the visit, that was the plan. And during the debriefing with my preceptor, this was a kind of a complex issue because of this teen's age, his non-compliance with medication, and trying to get, I guess, more family and friends support for him. But this teen has seen at least 2 other providers in the clinic, and it's always been the same issue of medication non-compliance. How are we going to get him to start taking his meds? So that is the biggest obstacle, challenge that the providers have for this particular patient is getting him to take his Synthroid every day. So hopefully he starts, now that his girlfriend is involved, his mom is involved, that he'll have a little more encouragement to take his medications, and we can see some improvement in the next 3 weeks and work from there. So like the guidelines for managing congenital hypothyroidism is just emphasizing the importance that it has on growth, development, and just overall health for this young man. But thank you. If you have any questions, please feel free to let me know. Recommendations, if we could have done anything differently, I'd appreciate it. Thank you.